Hello and welcome to the World Massage Conference. I'm Marla Gold and I will be your host for this class with Robert Libbey, who will be speaking to us about ligamentous articular strain techniques for ankle injuries. A reminder for those who have signed up as a full registrant, you'll have access to all quizzes. Simply click on the quiz link and review the questions before the class starts, and you'll be able to take the quiz right away to get your certificate of completion. Our instructor will be in the chat room for the live class to answer as many of your questions as possible. Now, just before we begin, I'd like to thank our sponsors. Thank you to our global sponsor, Massage Envy. Massage Envy is a community of caregivers committed to helping people feel their best. They believe that therapeutic massage and customized skincare are an integral part of the well-being journey. If you share this belief, they'd like to get to know you better. Learn more at massageenvy.com/careers. Thank you to our education partner, ABMP. Associated Bodywork and Massage Professionals provides an extensive array of member benefits and exceptional liability insurance. Visit abmp.com to discover why over 80,000 massage and bodywork professionals have chosen ABMP as their professional association. Thank you to our daily sponsors, Massage and Bodywork Magazine, Bon Vital, BioFreeze, and Massage Warehouse. Ligamentous articular strain techniques for ankle injuries. In this class, Robert will review some of the current research supporting ligamentous articular strain techniques and discuss why you should think about peripheral joint injuries as much more than just musculoskeletal injuries. You'll learn 3 strategic ligamentous articular strain techniques for the ankle and lower leg you can immediately add to your practice. You'll also learn simple strategies to get your patients walking better and to improve their kinesthetic balance. Robert will demonstrate 3 taping techniques for the ankle and lower leg to continue the neuroplastic changes we attain with manual therapy. Robert Libbey. With 23 years of experience as a registered massage therapist in British Columbia, Canada, Robert believes that injury resolution and effective management of conditions are best accomplished through innovative, precise, evidence-informed techniques and patient education. He's been teaching ligamentous articular strain techniques across Canada since 2010 and internationally in 2017. From 2001 to 2008, he instructed at the West Coast College of Massage Therapy in their orthopedic and neurological examination departments and was also a senior clinical supervisor. And now I'd like to welcome our presenter, Robert Libbey. Robert, it's wonderful to have you present with us today.
Hey everybody, I'm Robert Libbey, registered massage therapist and instructor of ligamentous articular strain technique. Thank you so much for being here today. I greatly appreciate the time and the effort that you guys are taking out of your lives in order to be here at this webinar. Thank you so much. I have to say a huge thank you to Melanie and Eric and Marla for all of their amazing hard work that they do to bring instructors like myself and webinars like the World Massage Conference to all of you. The main reason why we all do this, why we put in the personal time, is so that we can help to educate, those of you that are out there so that you can improve the quality of life of your patients, you can improve your education, and there's only so much that we can do as therapists within our own 4 walls. There's only so many patients that we can treat in a day. For those of us as teachers, there's only so many therapists that we can influence and educate in a classroom. And having Melanie and Eric and Marla work their tails off for the World Massage Conference to bring this information to you guys, it's just a fantastic venue to have a greater reach and influence a little bit more and educate our profession in order to make improvements in the quality of life of our patients, and that's the main reason why we're here. So again, thank you so much to those 3 for doing this for us as educators. Who am I? I'm a registered massage therapist. I've been practicing since 1994. I teach a postgraduate technique course called Ligamentous Articular Strain Technique, and I've been very pleased to have been part of the World Massage Conference all last year. I was at the Canadian Massage Conference in Ontario, which was a fantastic venue also. And I just love treating and love getting the message out about how we as manual therapists have an amazing ability to improve the quality of life of our patients through our hands and through our techniques and through how we communicate and the rapport that we build with our patients. So that's basically me in a nutshell. Now today what I'd like to do is, I've got some notes here, I got my timer, I got a short period of time to have some communication with you because I really want to dive deep into the techniques, really get some information into your hands so you can start incorporating this into your practice right away. And so my goal today is to actually transform how you guys think of ankle injuries, how you think of ligaments. I don't want you thinking of them as just musculoskeletal disorders or musculoskeletal tissues any longer. So we're gonna talk about that a little bit. For those of you that stay until the end, I've got a couple of giveaways. Who doesn't love giveaways? I've got some of my ligament pain referral pattern posters that we're going to give out to two fantastic viewers of this webinar today. And also I'm going to give you some discounts on some online continuing education courses that I've developed so that you have access to these videos for the rest of your career. You can bring them up on your iPhone, your iPad, your Android tablets and phones, your computers. You bring them up in treatment with your patients. Follow along with the demonstrations while I'm working on a patient. You're going to be working on your patient. And then you can let me know how you did and the benefits that your patient and you saw in the treatment. So that's for the end. And also at the end, I'm going to give you a little bit more information about how I'm improving, how I'm going about accomplishing my goal of improving the quality of life of people that are suffering in pain on a global scale. So what I'd like for you guys to do right now is to download the course manual for this webinar. Now this is a 51-page course manual. It gives you all of the evidence-informed research that the technique is supported by. It's all the information that we covered in the first webinar at the World Massage Conference last year and at the replay that we did earlier this year, or at the end of last year, sorry. So all the information is in there. You get all the information about ligament pain referral patterns, the neurophysiological model for referred pain. You get the colored images, colored pictures with the descriptions and all the information, the bibliography, the references, and a little blurb about me at the end. So it's a full course manual. It's the exact same information that I handled at my live events. So that's for you guys. So today, my promise to you is that I'm going to challenge you guys on how to think a little bit differently when you think about working with the ligamentous tissues. I'm also going to show you 3 techniques that you can immediately incorporate into your practice right away. I'm going to show you some home care. We're going to run through some kinesthetic balance coordination retraining exercises, and we're also going to look at how to retrain gait with our patients that have got ankle injuries or conditions. And I'm also going to show you 3 taping techniques in order to prolong the neuroplastic neuromodulation, arthroneuromodulation effects that we get with our hands when we work with the ligament joint capsule tissues. So it's really cool to work with tape. I implore you guys to take a taping course. It's absolutely fantastic for your patients and for yourself. And we're going to do that all in an hour. So I'm just looking at my clock here. I got 10 minutes left. So what we're going to do is get going. So this is a bit of a review. For those of you that joined me in the last webinar, Ligamentous Articular Strain Technique, last webinar, maybe I should say previous webinar, we talked a lot about ligaments, and what we were basically taught about ligaments is that they're viscoelastic, they're part of the articular cartilage or capsule in some cases. They can act as mechanical reinforcements for the joints, and they have a sensory and a motor portion to them, so they provide kinesthetic, proprioceptive information to the central nervous system. They also work in conjunction through a ligamentomuscular reflex with the muscles to help tighten them up. We know that from 2009 in a research paper that Jaap van der Wal published that ligaments are mostly arranged in series, not in parallel, which means that they're not separate tissues like what you think they are, and that anatomy textbooks kind of portray them as. They work in series. So basically, if you contract a muscle tissue, it engages the ligament. If the ligament engages because you're in the middle of going for an inversion sprain, the muscle tissue gets a signal, it will tighten up also. So they work in series with one another. They're not in parallel. And this quote is from Robert Schleip, who said this in a Fascia and Sports Medicine DVD. I'm quoting him now, ligaments and joint capsules are now seen not as completely separate structures, but they are embedded local densifications, local specifications of a body-wide collagenous, fibrous, mostly tension-driven, interconnected system. That's a lot of words. Basically, the ligaments are not separate. They work in series, and they are a embedded local densification specification type of fascial tissue. Now, I'm going to get you to think a little bit differently. For those of you that weren't in the webinar from the World Massage Conference, what we did is we covered a lot of new research into looking at how ligaments in the central nervous system, peripheral nervous system, were interconnected together, and I introduced a term to you guys, arthroneuromodulation, and I kind of stole it from the dermoneuromodulation people because I thought it sounded pretty cool, and it really did describe accurately what the ligaments are and how they do work with the tissues. So arthroneuromodulation is a messaging from the peripheral joint tissue mechanoreceptors affecting neuroplasticity of the central nervous system, and this is all from research. This is nothing that I'm making up, it's all research. Neurophysiological and neuroimaging studies have provided evidence for central nervous system reorganization, also known as neuroplasticity, at both the cortical and spinal levels after peripheral joint injuries. Neuroplastic changes may help to explain the transition from acute to chronic conditions. They may also explain why some patients continue to experience pain when no structural cause can be determined, why some patients fail to respond to conservative interventions. Also in the research, it shows that manual therapy affects the autonomic nervous system along with the connective tissues of the body. And again, this is some more research that the arthroneuromodulation or mechanoreceptor specific techniques targeting peripheral joint tissues have been shown to affect autonomic functions such as you'll see patients that will have a lowering of the sympathetic nervous system. They'll have a global decrease in deep tissue pressure sensitivity, so they can take a little bit more of a deeper pressure when you're working with them in clinic. They have increased pressure pain thresholds, lower resting pain perception, so they're not in pain as much when they're not moving. They have increased local proprioceptive attention, so they have better balance, coordination, kinesthetic awareness, decreasing muscle tonicity, so there's less sympathetic protective mechanisms that are in place, and there's a change in local blood supply to the local tissue viscosity. That was a really interesting part of some of the research, is that you showed that you can actually have a vascular effect by working through the ligaments in the joint capsules. In 2012, Peter Viklund also published a paper that showed that specific myofascial receptor techniques may have a longer lasting effect than classical Swedish massage techniques, and he also said that therapists might be encouraged to aim their soft tissue techniques to an area where there's known to be a high density of mechanoreceptors, which is basically at the tenoperiosteal and the ligamental periosteal junction. That's where these techniques are focused at, and how we work with the central nervous system. We work with the central nervous system. I got 4 minutes left. We work with the central nervous system with our hands. We work with it through the mechanoreceptors, which are present in every tissue in the body. But for the sake of this technique, we're going to be focusing on Golgi receptors, Pacini receptors, Ruffini, and the interstitial receptors. And so working with those receptors, which we all do with all techniques, you gain access to that neuroplasticity and the neuromodulation effects into the central nervous system. So really, when you think about soft tissue injuries, peripheral joint tissue injuries with the ligaments and joint capsules, this is my definition that I've sort of come up with, that ligamentous injuries are now seen as neurophysiological dysfunctions influencing executive functions such as processing of somatosensory information by the prefrontal cortex, causing reorganization of the central nervous system affecting neuroplasticity. Now I know that that's a lot of information in a short period of time, so you guys are going to be able to go back and re-watch this with some of the replay, and also when you sign up for any of the online courses that I present, all of this information, all of the neurophysiology, the research, the science, the PubMed screenshots, the bibliography, the research, the course manual, everything is included in the full online courses that I've developed for you guys. So today, what we're going to do is we're going to get you right into techniques right away. I got 2 minutes left. These are 3 techniques that I pulled from my online course for the leg and foot, and they are the 3 primary techniques that I utilized with a patient of mine I talked about in the previous webinar, who was a stunt woman in Canada. We had an amazing effect. We were able to get her standing, walking, full balance, almost full gait in 90 minutes, and she had had a severe 3rd-degree ankle sprain. She'd been in an air cast for 8 weeks. You can go to I'll have a download here in a little bit where you can go to that link and you can download her story that I had written for the Massage Therapy Canada magazine. Going through a little bit of some anatomy. Here we have the foot. This is a basic anatomy of the structure. So we've got navicular on the medial side, cuboid on the lateral side. We've got the cuneiforms that fall in line with 1st, 2nd, and 3rd rays. And then the 4th and 5th come off the cuboid. We've got the general ligaments of the lateral aspect of the foot. Don't worry, for the exam for this webinar, I won't expect you to know each and every origin, insertion, and action of these ligaments. But here is the medial aspect with the deltoid ligament and also the plantar calcaneal ligament, which we're concerned with also. We also need to look at the tib and the fib and the interosseous membrane and just remind ourselves that the tib and the fib, they move independently from one another, and they are both affected with any type of ankle injuries. Speaking of the injuries, again, this is Rochelle. I talked about her and showed a video of what her life is like from day to day with her work as a stunt woman in the last episode. Here is the link that you can go to for the download of her story that was written for the Massage Therapy Canada Spring 2016 edition. Here's a couple of images from Google that you can just search out. We've all had patients that have come in looking like this with their ankles after a severe ankle injury. This is an image of a new patient of mine, actually, that I utilized these techniques on. This is a image that was taken 6 weeks ago from a patient of mine who came in with a distal fibula fracture. She got it from skiing. The skis kind of pointed in noseways, and she lost her balance. She had a distal fibula fracture, and 6 weeks later, once it starts to unionize, we can actually work with these tissues with the techniques that I'm going to show you today. Ligaments have pain referral patterns. George Hackett back in the 1950s did some research where he injected over 1,500 patients with 20,000 ligamentous injections. That's a lot of research, and he was able to show that ligaments actually had pain referral patterns. Now I know pain referral patterns are being challenged in our industry right now, and there's a lot of call for the evidence-informed research to justify them or to support them. So Hackett's referral patterns, there's a lot of research into that. And the neurophysiological model for referred pain, I'm not going to get into detail about this right now because it is included in the course manual, and I covered that in the previous webinar. But just know that there are specific pain referral patterns for specific ligaments throughout all areas of the body. And in the posters that 2 people are going to walk away with for free today, there's over 40 images of the ligament pain referral patterns. So without any ado, what I'd like to do is jump right into the techniques. Again, we're going to be looking at the boot jack technique, a technique for a talus that's sitting a little bit anterior, and also a technique to work with the fibula. Very important to work with the fibula when you've got patients with ankle injuries, either a sprain or a strain. So enjoy the technique section of this webinar. These are videos that I've pulled from the online course. The exact same videos are included in the full online course, and I will see you guys back here at the end of the techniques, at the end of the home care kinesthetic balance coordination retraining section, the gait retraining section, and the 3 taping techniques section. I will see you guys back here right at the end. Thanks guys, enjoy the videos. Okay, for this first technique, this is called the boot jack technique. Now, the history into the name of this technique is that you have to remember that these techniques are all developed from Andrew Taylor Still from the late 1800s and the early 1900s. Now, back then, he was working on a lot of men who were prospectors, and they were wearing the prospector's boots, which were very tight and very confining onto the foot. Because when you're prospecting, you're in the mud and the muck, and you're out into the forest and stuff, and you don't want your boots to fall off. So the boots were very confining onto the feet. Now, when it came time at the end of the day, in order to remove the boots, what the prospectors used to do is they used to slam their heel into what was called a boot jack, which would lock around the boot, and then they were able to remove their foot from the boot, keeping the boot in place on the ground. And what he noticed was that a lot of the prospectors didn't have a lot of the foot and ankle or lower extremity complaints that the non-prospector people did. So he developed this technique in order to create an environment where the talus and the calcaneus were disengaged away from the tib and the fib in order to increase space, change the environment, and basically bring or assist that talus in becoming into more of a neutral position. So this is what the technique looks like. With your patient lying face up, you take your arm around the inside of their lower extremity, and you attach your elbow into their hamstrings, and you grasp on the medial side of the calcaneus. You grab onto the medial side of the calcaneus with your thumb, and then on the lateral side of the calcaneus, you use your index finger. And our goal with this is to take the talus and the calcaneus distally away from the distal portion of the tib and the fib. Now, when we're doing this, we're going to be locking our elbow into our patient's hamstrings. We're going to be taking our arm in this direction, disengaging that talus and that calcaneus away from that distal end of the tib and the fib. And what you'll notice is that there is a little bit of a rotation and a wiggle that will occur as the tensional forces on the medial and lateral aspect of these bones start to become more balanced. Now, you can sort of influence with an indirect technique and a direct technique by mobilizing or by influencing through the metatarsals, while this talus is slowly wiggling itself out of its dysfunctional position and more into a neutral position. So this is where our start and our end point is, and all of the movement and all the things that you'll be feeling is going to be happening down through this end. So let's see what this looks like with our patient. Okay, everybody, this is the first technique, the boot jack technique, that we will be performing in this online course. This is Jani. She is a registered massage therapist, and she actually has sprained her ankles a number of times. So this is definitely an appropriate set of techniques that we will be using with her. So again, these aren't demonstrations, these are actual treatments that you're going to be seeing. She will be actually getting treatment from me while I'm demoing for this course. So standing on the same side as the affected leg, what we want to do is very nicely bring the leg into a 90-degree position with the femur at the pelvis, about 90 degrees of the femur at the knee. You want to take your arm on the medial side of your patient's leg, and you want to grasp your thumb onto the medial side of the calcaneus and your index finger onto the lateral side of the calcaneus. Now, this is a great position to be in because we can lock our elbow into our patient's hamstrings, and we can sit back a little bit in order to gain enough force in order to draw the calcaneus and the talus distally away from this lower extremity, from the distal tib and fib. So with your thumb and your index finger in place, gently grasping that that calcaneus, your other hand can come across right onto the dorsal side of, you can have your thumb on the dorsal side of the foot, fingers on the plantar aspect of the foot, so that you have this ability to incorporate a direct technique into this technique. So to start, we like to try and have the foot in as neutral of a position as possible. Lock your elbow into your patient's hamstring and very slowly draw that calcaneus distally away from the distal tib and fib. Immediately, you may feel that the foot has a direction of ease. Usually, it can go into the direction that the ankle had previously been injured in. And sometimes you'll have the ankle draw you into more of a protective, compensating position where it draws it to the exact opposite position. There's no right or wrong. Every patient presents completely differently than the other. But we're just sitting, matching the reciprocal tension of the tissues, cooperating with the tissues, and allowing enough time for these tissues to be drawn distally and to really influence that talus more into a neutral position. Now, if you find that your thumb and your index finger start to slip off of the calcaneus, you can stop, you can reposition. If you need, you can actually grab a towel and you can place a towel between both of your skins so that you have a little bit more grip and your fingers don't slip. And then just start over, go back to your start position, re-engage the tissue gently, let that indirect technique control the release and the change in the environment. There may be a little bit of a cogwheel effect that you feel while this is recentering itself. With some patients, I've had a clunk happen where the talus actually clunks back into place. And when everything gets to the point where it's sitting in a very balanced, neutral position, I like to hang out here just to give her physiology enough time to get used to being in this position and allow the central nervous system to remember or imprint that this is more of an appropriate placement and position to be in than the dysfunctional position that we originally started with. So once everything has come to a balance point and the tissue feels like it's completely softened, it doesn't feel like it has the amount of tension or tensional forces that it had initially, then you can slowly come out of the position and you can put the leg back to your start position and reassess their range of motion. For this technique, this is a technique that treats a talus that is sitting in an anterior position. Now, with your patient lying supine, what I want you to do is come to the end of the table where I'm at. You're going to have your hands on the plantar aspect of the foot, and your thumbs are going to come into contact right at the distal end of the tibia. Now, with people that have had injuries to the lower extremities where their gastrocs and soleus in the posterior compartment have gone into a protection mode or a guarding mode, you'll have an increased neurological stimulus which causes those tissues to have a higher tensional force on them. There'll be a lot more tonality to the tissues. And what it does is it places the position of the foot more into a plantar flex position. Now, when you take the foot into a neutral position or into a dorsiflex position, like what happens when people are heel striking, a lot of patients will complain of a pinching or a sharp pain that they get through the anterior aspect of that lower extremity. The majority of the time, the reason is because this talus has been drawn so much into a position of being anterior that when they go into dorsiflexion, you get a bone-on-bone compression and you get an irritation of the soft tissue and the aponeurosis, the ligamentous tissue, and the tendinous tissue in through this dorsal aspect of the foot. So to determine if the talus is sitting anterior or not, you really have to feel if you can feel the distal end of the shelf of that distal tibia. If you can't and you can only feel the talus, then this talus is sitting in an anterior position. Our goal with this is to draw the talus, having the calcaneus off of the table. You want to be able to slowly load your weight through your thumbs onto the talus and draw that talus more into a neutral position so that your thumbs come in contact with that distal shelf of that tibia. Now there may be a little bit of a supination that occurs through the talus. There may be a little bit of a pronation that occurs through the talus, through the talus as you are drawing this talus more into a neutral position. But it's really important that you get this talus neutral in order to reestablish proper gait mechanisms and proper ranges of motion for this foot. So let's see what this looks like with our patient. Okay, so with our patient on the table, what I want you to do is gently grasp their foot, make sure that their calcaneus and talus are off of the table. And what I typically do is I use my thigh, my lateral thigh, in order to place it onto the plantar aspect of their foot so that I'm not using a lot of upper body strength in order to hold this foot into this position. What I like to do is just place my lateral thigh into their plantar aspect of their foot so that it's a lot easier to get it into this neutral position. Now, slowly placing it into a neutral position with your thumbs, I want you to feel for, again, that distal shelf of that talus, or the shelf of the distal tibia. Now, if you can only feel the talus and you can't feel that distal shelf of the tibia, then that talus is sitting in a neutral position. So with her, it's sitting just very slightly anterior. So this is a great technique for her. So with this technique, again, take the foot into a neutral position, have your thumbs nice and straight, loading right onto that talus, and I want you to load directly down into the floor. I want you to load your thumbs right through that talus into the floor, and there may be a little bit of a supination that occurs in the talus. With her, the direction of ease is more of a pronation for this talus. So I'm going to start in that position of ease, that pronation, with a direct technique of me using my lateral thigh to mobilize her foot and my thumbs. I'm going to place her talus more into a neutral position. I can feel the tensional forces on the medial and the lateral aspect of her foot are now more into a balanced position. And then I'm going to gently load my weight through my thumbs into that talus down into the floor. We're going to hold this position until everything softens and it becomes effectively effortless in order to hold this position. Now this can take anywhere from 30 seconds to 90 seconds with some patients with very chronic, severe, sort of dispositioned taluses that have been there for up to a decade. It may take 5 minutes in order to allow the tissue enough time for a balance to be created. Once you get to the point where everything softens and you can feel a balance in the tissues that's taken place, again, feel for the talus, feel for that distal shelf of the tibia. If you can feel for that, and you can also feel the joint space between those two structures, her talus is now in more of a neutral position, and the technique has come to an end. Working with the fibula of the lower extremity, our goal is to increase inferior distraction in order to disengage this proximal tibiofibular joint. The reason for that is because this joint can become compressed together with the assistance of the biceps femoris attachment after there's been some type of injury into our patient's lower extremity. As I said in the previous video, with patients that have suffered from an inversion type of sprain, the calcaneofibular ligament and the peroneals will be pulling this fibula in an inferior fashion, which then causes a lengthening to occur through this biceps femoris, which when goes into a protective mechanism can jam this fibula back up into the tibia shelf where it's attaching onto. If we have any patients that are suffering from an eversion sprain, well then calcaneus can actually jam into the distal fibula, jamming that fibula back up into the proximal tib-fib joint. So we really do want to increase some functionality through this joint. Now the position that we place our patient's knee into is one where we have our elbows resting on the table, taking the full weight of our patient's leg. Now what I don't want you to do is I don't want you having your elbows off the table. The elbows can rest on the table, and this is a very effortless, easy technique to perform as the therapist. Now what I want you to be able to do is have your patient's calcaneus resting in your hand. I want you to be able to palpate that calcaneofibular ligament, and I also want you to find again that middle joint space at the knee between the lateral condyle of the femur and the lateral plateau of the tibia, and then find that proximal bony protuberance of that fibula where the where the biceps femoris hamstring attaches onto. In order to assess the movement at this proximal tib-fib joint and the fibula in general, you want to, in a direct technique, you want to take your patient's foot into an inversion position, which will or should pull this fibula in an inferior fashion. We want to be concentrating on our thumb at the proximal position while we take the foot into that inversion position, because we want to be assessing what the motion, the permitted motion is at that joint. If there isn't any motion at that joint, then it needs to be treated and we need to draw this fibula inferiorly. So let's see what that looks like with our patient. In treating your patient's fibula and assessing for its permitted motion, what we do is, again, we have our patient's calcaneus in one hand. We've found the proximal head of the fibula with our other hand, and we're slowly going to elevate the leg, keeping our elbows on the table, being able to find that distal tendon of the biceps femoris where it attaches onto that proximal fibular head, and we have the calcaneus in our palm down at the distal end. So what I'd like to do is remember that we don't want our thumb hyperextended at that proximal end. We want to make good contact with the proximal surface of that fibular head. With our hand at the ankle, we have the ability to take the foot in from an eversion into an inversion position. And while we do that, we can assess to see if there's any movement that's happening at this proximal head. Now you can see that we have some movement through the skin, but we don't have any movement at that joint. So I should be able to feel some movement happening at that joint, and I can't with her. So this technique is appropriate for her joint. So what I'd like to do is engage the tissue, bone-on-bone contact. I like to take her foot into an inversion position, and then locking my thumb onto the proximal portion of that fibula, I like to draw it inferiorly and try and gap those two bones apart from one another. It's a very minimal amount of space that you're going to be gaining. Now, if you wanted to incorporate some activity from the patient with this, I would actually ask my patient to invert the foot a little bit more, which then has the ability to draw that fibula further away from that proximal attachment at the tibia. If you find that your thumb is slipping off of the skin, you can slowly reposition and continue the treatment technique and wait for an increase in elasticity and suppleness to occur through that joint. We'll get her to relax while I'm holding the joint in that position. We can go back to our start position, find that proximal fibular head, take the foot into inversion, and then go back and forth. And there is now an increase in range of that fibula moving through an inferior distraction. It's not just the skin, it's actually the head that is moving inferiorly away from its attachment at the tibia. So engaging that tissue and reestablishing proper mechanics and fluid dynamics and stimulating the mechanoreceptors through this tissue, we are assisting the body in recreating better proprioception, balance, and coordination through this area, creating more functionality through the environment, through this bone, and through the lower extremity, and allowing the ankle to actually have a little bit more range also. So this is a great technique for any of your patients that have either had an eversion sprain or an inversion sprain that have caused a decreased range of motion to occur at this proximal tibiofibular joint. And it's great to get that inferior distraction happening through this bone. So try that with your patients, and I'll see you in the next video. Okay, everybody, welcome to the home care portion of the webinar for the ankle injuries. With these types of patients, we really want to send them home ensuring that we continue the neurological effects of our treatments. We want to continue to access that neuroplasticity with the central nervous system, because we looked at the research that showed that, especially with twin studies, when you've had one twin with an ankle injury, the other one with the same ankle injury, one gets better, one doesn't. The main reason that the research has shown why one was able to return to full function and one wasn't was because of the neuroplastic changes. So it's really important for you to send your patients home with home care activities that they can do on a daily basis. Usually I send my patients home and I let them know that they can do this at breakfast, lunch, and supper, and that it's really important just to reestablish a neuromuscular messaging to create some stability in through the ankles. So the first thing we need to do is we need to assess to see which ankle was the worst and what their current stability and balance, coordination, proprioception is right now. So which ankle is your worst?
Right.
The right ankle is. Okay, so what we need to do is ensure safety for our patients immediately. So what I'm going to get you to do is to hold on to a chair, and standing on the right leg, what I want you to do is just slowly balance just on that leg. So eyes are open, looking nice and straight, balancing on the leg, and I'm going to get you to let go of the chair, and you're going to balance as long as you can. So we've got a little bit of firing that's happening through the anterior and the posterior compartment. You actually look really stable. This is not helping for the webinar. All right. So no, this is good. So she's actually got not too bad stability, kinesthetic, balance, coordination, proprioception. So what I'm going to get you to do is going to move on to the next stage. Is you're going to hold on to the chair again. You're going to stand on the affected leg. You're going to let go of the chair. Okay, we're doing pretty good. Okay, hold on to the chair again. Still standing on the leg. Now you're going to close your eyes, and now you're going to let go of the chair. And she immediately starts to go. So we need to do a little bit of staggered balance, coordination, proprioception, retraining, sort of a neuroplastic modulation exercise. So this is something that you're going to do breakfast, lunch, supper. You're going to hold on to something stable, hold on to a chair. You're going to start with your eyes open, standing on the affected leg. stand there as long as you can. And then what you're going to do is hold back onto the chair. So let's do this again. So holding onto the chair. And then standing on the affected leg, closing the eyes. And then letting go of the chair. And slowly seeing if you can still stand a little bit longer. So this is great for really challenging that neuroplasticity and getting that neuromuscular messaging firing on a more consistent basis. So once your patients get to the point where they can actually stand on a stable surface with their eyes closed and they're not going to fall over and they don't need to support themselves with a chair, then what you can do is you can increase the challenge a little bit more. So I'm going to get you to stand on one pillow. So now we're on a stable surface, but it's a little bit less stable than what we initially started with. So again, you're going to stand on the affected leg, holding onto the chair. Eyes are going to stay open for the first portion, letting go of the chair. It's a little bit more challenging, a little bit more engagement with the tissues. Not too bad. Okay, standing on the affected leg, holding onto the chair, closing the eyes, and then letting go of the chair. Little bit engagement. Okay, let's go back to that again. So holding onto the chair, standing on the affected leg, eyes closed, letting go of the chair. So that would be the next step, going from least invasive to most invasive. Once she was able to get to a point where she was completely stable standing on one pillow, then what you can do is you can increase the challenge again and you can stand on a second pillow. So again, holding onto the chair, staying on the affected leg. We'll go eyes open, letting go. Ankles working a little bit more. This is good. And now you're going to hold onto the chair again. Eyes closed. This is where the exciting part happens. Now you can really see the foot start to be challenged. So that neuromuscular messaging is really important to reestablish some support, some basic function. It's absolutely fantastic for sending your patients home for home care to do on a regular basis. You can do it on a daily basis. Again, I tell my patients do it breakfast, lunch, supper. Do it for 3, 4, 5 sets at each of those times. And it's just a nice, easy, free way that they can do their home care and, again, increase that neuromuscular messaging to create that neurological stability in through that ankle. So that's what I typically send my patients home with. From there, we get a little bit more advanced with this stability and the strengthening activities. But for now, I would love for you guys to send your patients home with this activity and let me know how you do and what the results are with your patients. Thanks, guys. Okay, everybody, thank you for being here with us today. We're coming to the taping portion of the webinar, and the reason why you want to incorporate taping, or the reason why I feel that it's important for us as manual therapists to incorporate taping into our treatments is that I feel that it extends the neuroplastic changes that are taking place with our patients after the treatment. It's really important that we continue to have those neuromuscular modulations taking place in order to reestablish proper neuromuscular firing and get some more balance, coordination, kinesthetic awareness happening to these tissues. And again, it just provides a little bit more stability for a longer period of time for those patients. With taping, there are various tape products that are out there. For my own practice, I use Rock Tape. I'm not associated with them whatsoever. I'm not receiving any money from them or any funding whatsoever. I just like the product. But there is Kinesio Tape, there's K-Tape, there's lots of other products that are out there that you can use. They're a little bit different than the zinc oxide athletic tape. The zinc oxide white athletic tape, which you're probably all used to seeing on all of the athletes, is very restrictive, very tight. You would use that for more of an acute ankle injury where you need to provide stability. But this is more for, we're taping for posture, for performance, and for pain. So if we have someone who is in pain, what's happening is that these tissues are sending up to the brain and spinal cord, they're sending danger messages. They're sending threat messages. And the brain and the spinal cord, they perceive these threat messages and danger messages, and they think, well, what are we supposed to do with this? We need to protect and guard, so they tighten up the tissue and they elicit a pain response, which then makes you stop doing the activity that is eliciting that danger and threat message. So we need to change that message that those nociceptors are sending. And what the tape does is it sends a kinesthetic proprioceptive message. So now the brain is no longer getting a danger threat message, it's getting a kinesthetic proprioceptive message, and it allows again for a little bit more increased stability, neuromuscular, ligamentomuscular firing to create some stability and again change that pain. For performance also, we want to make sure that they have an increased awareness and balanced coordination kinesthetic awareness, so the tape is going to provide that also. So again, pain, posture, and performance are the main reasons why we use this type of athletic tape. Again, it's a different type of tape than the zinc oxide white tape, but it's fantastic for extending your treatments and for providing some stability, some balanced coordination, kinesthetic awareness, re-education. It's a neurological re-education. It really isn't going to provide a whole heck of a lot of stability, so it's not really used for that. So I think, again, it's a really important adjunct that you can apply in your treatment and in your practice. And again, it's just an additional way that you can ensure safety and care after your treatment. So let's have a look at the taping techniques that we're going to use today. Okay, so for today's lesson in taping, we're going to utilize 3 taping applications. We're going to do a simple U-lock taping technique where we go around the medial malleolus, around the foot, and then providing some support and re-education, neuromuscular re-education to the lateral aspect and the peroneals. This is mainly used for people that have had some type of an inversion sprain where they've sprained their ankle this way. So again, the lateral aspect is getting stretched and elongated. We're getting those danger threat messages that are happening in through this area. So we really want to keep them in a neutral position when we are using that U-lock taping technique. We're also going to be utilizing a heel lock technique where we stabilize the calcaneus around the distal end of the tib and the fib. And then we're also going to utilize a figure 8 pattern where we provide general stability to the whole foot and around to the distal end of the tib and the fib. So I've got some pre-cut, pre-measured tape that I'm using. Again, this is the rock tape. Again, we tape for pain, posture, performance. To begin with, what we want to do is we want to have our patient's foot in a neutral position. What we do with the tape is you peel off the end of the tape. We're going to come just superior to that medial malleolus, and we're going to tack the tape down onto her skin with no stretch. We're going to pull the tape, the back of the tape off so that we've got full access to all the tape. Again, no stretch at the tacked portion where we begin. We're going to slowly come around the medial malleolus, and we're going to provide a little bit of stretch. Now you can do 100% stretch. We're going to come back to about a 50% stretch. It's going to wrap right around the lateral aspect. I'm going to keep the stretch on as we go over the lateral malleolus. Where we come up onto the skin, I'm going to release the stretch, and we're just going to tack the tape down. We're going to give a little bit of a rub to activate the adhesive on the back side of the tape. Get that crease out of there. The next taping portion, or taping technique, that we're going to utilize is a heel lock technique. So again, this is to stabilize the calcaneus. So we're going to start with, again, the tape on the medial aspect of the arch. Again, I've pre-measured and cut this. So again, no stretch around this area because it can actually become quite sensitive for the patients. As I get around the foot, it is going to wrap right around her heel. be sure to tack that down. Continuing to take the tape off, again, wrapping around the heel and coming right back to where we started. So there is a nice heel lock. It's all supported through the calcaneus, through the metatarsals. And this taping technique is going to be a figure 8 taping technique. So we're going to peel the end off. We're going to tack it down with no stretch onto the skin. I'm going to start to peel the tape off. We're going to wrap around with no stretch. We're going to come up and over the top of the foot with no stretch. Now when we get to the medial part, when we're coming back, I'd like to place a little bit of stretch around this area. Just as it goes around, no stretch around the Achilles. And then backing up and over, ending the taping technique with no stretch on the lateral aspect. And that is your figure 8 taping technique. So we've got a nice amount of stability that's happening on the lateral aspect of the foot. We've got some neurological engagement happening for the peroneals, and we've got some nice stability for the medial aspect of the foot also. So if we let her foot just relax and go down, it's nice and stable, it's in a neutral position, and this is a great application that we can send our patients home with. The tape can stay on for 3 to 5 days. They can be active with it, they can get it wet, they can sweat with it. If the tape starts to peel off, then what they can do is they can just trim the edge of the tape and re-tack it back down. But after about 3 to 5 days, the neurological messaging or neuromodulation has been maximized, and it's time for it to start functioning on its own. We don't leave the tape on for a long period of time or do multiple applications back to back with the tape, because the body adapts and it becomes ineffective at that point. So there are your 3 taping techniques. We've got a U-lock taping technique, which is the orange. We've got the heel lock taping technique in order to stabilize the calcaneus and the talus and the distal tib fib. And then we've got the figure 8 technique in order to provide a little bit more stability for those metatarsals that may have also been involved for the lateral aspect and for the distal end of the tib and the fib. So I would encourage you guys to take a taping course, incorporate these into your practice. It extends the neuromodulation and the neuromuscular firing, the ligamentomuscular reflex that we really want to take advantage of in order to create a long-term rehabilitative state for this patient. So there we go. Okay, everybody, thanks for coming back. Thanks for watching those videos. What I'd like to do right now is get you guys a little bit informed on how to and why you should re-educate your patients on how to have a more functional gait, how to get your patients walking more functionally after they've had some type of ankle injury. Now, what we've typically seen in our patients and in ourselves also, that when we've had an ankle injury where we're dealing with some pain and protective mechanisms, some guarding mechanisms in through the lower extremity, is that we no longer walk in a straight pattern. We actually externally rotate the foot in order to avoid those painful positions, those painful patterns, those painful tissues. And what happens is that you start impacting more on the medial side of the calcaneus. It starts having an effect on the medial collateral ligament, the medial meniscus of the knee, the muscles that insert into the pons insertion. You start externally rotating your pelvis, so there's some tightening into the glutes and the external rotators, and it just follows further up the chain. So it's really, really important that we get our patients walking more in a straight line and more functional. Now, as a reminder, there are 4 stages that we go through with gait. There is a heel strike that happens. There's a foot flat where they're sort of in a plantar flexion. There is a mid stance where the tib and the fib are directly over top of the talus and the calcaneus. And then we get to the propulsion section where it's a toe off and the toes are then propelling you forwards. So once again, we've got heel strike, foot flat, mid stance, and then toe off in order to propel you forwards. So let's have a look at someone actually walking on a treadmill. This is a patient of ours in our office walking on our treadmill, and as you can see, she's going through the 4 stages. She's got a heel strike, a foot flat, a mid stance, and a toe off. Now with patients who are in pain, they're going to be missing at least one or two of those. So it's very important to retrain that nervous system in order to walk forwards. We retrain it by going backwards. As you can see here, she's going through the toe off portion. And then we're at the mid stance portion where the tib and the fib are directly over top of the talus. Here is the foot flat. And then she's going to have a nice heel strike. So again, we'll look at this. There's the toe off portion. Next up is the mid stance portion. The tib and fib are over top of the talus calcaneus. There's the foot flat. And also there is the heel off. So again, when you're teaching your patients to walk backwards, they really have to do it really slowly. You have to be very picky about having them do a proper toe off, walking back slowly into the mid stance, getting them into the foot flat portion, and then when they go into the heel strike, they really do have to, you know, contract and get those toes to the nose as much as they can, because that's basically what happens when you're walking forwards. So we know how to get our patients walking forwards. You have to be very picky about being very specific and very precise about how they're going to walk in reverse. So I hope that serves you guys. I hope that you can incorporate that into your practice. If you're not already incorporating that into your practice, it's fantastic to watch your patients light up and see the nervous system trying to figure out how to walk backwards and how to walk forwards again. It's a fantastic technique that I hope you guys utilize, and I hope you enjoyed watching the video. Thanks, guys. Okay, everybody, thanks for watching those videos. I hope that you guys have really taken a lot of information in and have figured out and thought about the different patients that you've got coming up in the next week or two in your practice that you can immediately start utilizing these techniques with. I would love to hear back from you guys. I'd love to hear the comments, your testimonials. So please, you can go to my site, lastsite.ca. There is a tab at the top called Testimonials, and I would love to hear from you guys. It's what keeps me going, what keeps me looking to be more innovative with the techniques and find more research in order to support the techniques, and I just love engaging with you guys. So thanks for being here. So a quick review of what we did today, what you guys were able to watch. We went through the boot jack technique, the anterior talus, and the fibula technique. All of those are fantastic techniques. You can use them in any stage of condition, either acute, subacute, or chronic, obviously within your patient's pain tolerance. I want you guys to also think about your contraindications, your indications, and your precautions. Medications that they're on, what's the state of the tissue, do they have plates, pins, nuts, bolts, meshes, what kind of surgeries have they had in the past, how many ankle injuries have they had, what other injuries further up the chain do they have that you may have to modify the technique in order to deal with the pain that they're, or discomfort that they're suffering from further up the chain, either at the knee, at the hip, or at the spinal area, vertebral area, SI joints, pelvis. So even though I didn't get into depth into contraindications, indications, precautions for these techniques, it's all in the course manual, and in the online courses, the full online courses, I go through all of that for every technique, for every course that I do. So techniques for the shoulder, techniques for the knee, techniques for the leg and the foot. I've got a hip and pelvis coming up later on this year. We run through all the contraindications, the indications, and the precautions for those areas. So never forget that. You've got to deal with acute, subacute, and chronic, and all of those indications. So we're getting to the end. So for those of you that stayed until the end, congratulations. You're gonna, two of you are going to walk away with a set of ligament pain referral pattern posters. These are images that are based on George Hackett's research, where he did 20,000 ligamentous injections in over 15 or 1,800 patients, and he documented all of those referral patterns. So you guys are going to receive a couple of those. Melanie and I will go through the members that joined in with the chat today, and we'll just randomly choose a couple. We'll notify you guys by email, and I'll send them out to you right away. Also, what I would love for you guys to do is to download the course manual because in the course manual it has all of the same information that I cover in the live courses and in the full online courses. It's got information on pain referral patterns, the neurophysiological model for referred pain, gives you all the techniques in color with descriptions, and the bibliography and the references below also, or the references also. It also want you to download the Massage Therapy Canada Spring 2016 edition, where I documented the treatment that we did with Rochelle. She was the Canadian stunt woman with the severe ankle injury that she was air casted for 8 weeks, and it just documents what we were able to accomplish in just one 90-minute treatment. It was absolutely a game changer, an amazing rehabilitative tipping point for her. It actually put her on a trajectory that she was able to get back to work really, really quickly. We also covered, today we covered some kinesthetic proprioceptive retraining. We had Jamie standing next to a chair doing the eyes open, eyes closed, working with pillows underneath her feet. That was exciting to do. I also showed you 3 taping techniques, and for those of you that haven't taken a taping course, again, I'm not associated with Rock Tape, but I loved the course that I took with them. There's Kinesio Tape, there's K-Tape. You can take an athletic taping course where they use a zinc oxide, the white tape that they use for stabilizing. But for today, we went with the elastic Rock Tape, and I showed you a technique for a horseshoe taping technique, a calcaneal blocking technique, and then a figure 8 technique in order to provide as much stability and function for our patients going forwards after our treatments. And essentially what the tape does is it's just a neurological reminder. It's just a neurological stimulus and awareness. It increases the neuromuscular messaging that is occurring with our patients, and it's just changing the messaging that's happening. Instead of the tissues sending a danger or threat message back to the central nervous system, and then your central nervous system causing a hypertonicity or guarding mechanism or pain response, what it does is it sends a kinesthetic proprioception balancing message, and the body starts to learn that it doesn't have to be as protected, it doesn't have to elicit a pain response, and they start to rehab a little bit more effectively. And then we also went through the gait retraining, so getting our patients to walk backwards with the 4 stages of gait. So going forwards, it was heel strike, foot flat, mid stance, toe off. Going in reverse, very specifically, very precisely, very slowly, get your patient to go from toe off into mid stance, into foot flat, and then into heel strike. So I hope you guys all took away at least something from today's hour-long presentation. Again, for those of you that stuck around to the end, you can go to this website. It's lastsite.ca/CMC. I've got a huge discount for you guys for my online courses. Usually each course is $197 plus tax. Right now for you guys, you're going to get 25% off, so that's like $50 off each course. You can get any of the courses you want here for $145. You get full access all the time on any device, and there is no time limit. You can come back to it at any point in time. There you get lifetime access to these courses. You know, I had an amazing testimonial come to me from Africa, actually. One from Africa and one from India. They both came within the same week, and they were both basically the same story. Therapist was enrolled in the shoulder course. They were going to a Sunday family dinner. Their grandmother had fallen down, injured their shoulder. They were able to pull up the course and the techniques for the shoulder. They applied the techniques to their grandmother right at the time when they were just about getting ready for supper. The grandmother was pain-free and had full function for supper, and they had a fantastic time. You know, those are just fantastic testimonials that I love to see and I love to hear. And I love hearing from you guys. I like having the communication with you. So please, by all means, utilize these techniques. Don't just, you know, be here for the webinar. I want you guys to incorporate these techniques into your practice. I want you to think about what patients you can start putting these techniques into play with next week and the week after, and then communicate with me. Let me know how you did. Let me know I want to know your comments and your testimonials. So again, a huge thank you to the World Massage Conference, to Melanie, to Eric, and to Marla for setting this up. It's an absolutely fantastic venue for those of us that have the passion to educate and to have a greater reach and have a more influence with our skills and with our education, with our knowledge, in order to influence more therapists to have an improvement in the quality of life of their patients. It's the only reason why we're here. We're doing it so that we can end suffering on a global scale or a wider scale than what we can within our four walls. So once again, thanks for being here. I hope you enjoyed the webinar. If you have any questions or any comments, please let me know. Again, there's a ton of information at www.lastsite.ca. To get the discount, go to lastsite.ca/CMC. It's a 25% discount on every course. You get lifetime access again. And again, thanks for being here, guys. I'd love to hear from you guys, and we'll talk to you later. Bye, guys.